Oh, sorry.
Sorry.
So Aaron Beck is very important to us in that he was a trained psychoanalyst, and his study of psychoanalytic concepts of depression led to his development of cognitive behavioral therapy. So we want to frame how revolutionary Dr. Aaron Beck is. After, after Freud, right, who was very much driven by psychoanalysis, Dr. Beck changed the way we did therapy. Okay, so we went from a Freudian model to a more empirical model. Okay, so Beck's cognitive triad. I don't know if anybody's seen this triad, this triangle. So Beck developed this triangle, and the way he framed depression was this way. So the way we think of ourselves, right? If we have a negative view of oneself, I might say things like, I am worthless, right? On the other side of the triangle, the other corner, right, to the right side, there's a negative view of, I'm going to go to the top actually, to the negative view of the world, right? If I have a negative view of the world, I might think or I might say things like, everybody hates me because I am worthless. The right corner is a negative view of the future, right? So if I have a negative view of myself and then also a negative view of the world, there's a high likelihood that I'm going to have a negative view of my future. And I might think things like, I'll never be good at anything because everyone hates me. This triad is very important, right? Because it really shows me in relation to my world and my future and this sense of hopelessness and helplessness, right? And almost like a fatalistic approach ends up coming up when we look at this model. So Beck really, Beck talked about how a situation, an incident, a circumstance occurs in the environment. And what ends up happening is that situation will activate an automatic thought. It will activate our intermediate beliefs and then our core beliefs and schema, right? And that's exactly what we just saw in that triangle of negativity. That a situation will occur and we will automatically jump to an automatic thought about myself. In the example with depression, right? It's going to be, I am worthless. Oh my goodness, this thing is my fault. Ah, I can't do anything right, right? I'm just no good. And so it's very important to think about how the way we think, right? The cognition. And within the cognition, right, we think about judgments, assumptions that we have. Assumptions and judgments influence behavior. Okay. And this is this diagram. If I were to get a tattoo, I don't have any tattoos, but if I were to get a tattoo, this might look like my tattoo. And don't copy this, Larry. So this ABC illustrates in the A, that is the antecedent, which is another word, another fancy word for a trigger, an activating event. Okay. Inside the antecedent, right? We think about a judgment I might have, an assumption, an emotion. If I think of these kinds of things, it's going to influence a behavior. A behavior occurs and then there's a consequence. Okay. So let's say I look around the audience, right? And no one's talking, everybody's just staring at me intently, right? I might have some judgments. I might go to, oh my goodness, this audience finds my training already boring. They think it's useless. It's not informative. If I start to have these kinds of judgments, right, based on, I don't know, 5 minutes, 10 minutes of talking, my behavior is going to be influenced by the way I think. I might end up pulling back. I might not be, energetic, right? And then there's consequences to that behavior, okay, which is based on those cognitions. So I might say to Alyssa, do you want me to do a training next week? And she says, this trainer, no, she was not energetic, she was detached, right? She was withdrawing from the audience. So I think we need to think about how the way we think really influences the behaviors. Okay. In the antecedent, right? In our cognition, I'm going to pull up this slide, which is there's some common cognitive distortions. Okay, so these are some of the common ones, and I think we're all guilty of having some of these distorted cognitions. Okay, this is the automatic thoughts, right, or assumptions that we tend to go towards. One of them is selective abstraction, right? Which is drawing conclusions on the basis of just one element of a situation. So one thing goes wrong, and I really I jump to a conclusion, or I think everything went wrong. Okay, personalization. Sometimes some of us personalize things, right? That we think this is my fault. Something happens in the environment and we think, oh my gosh, this is my fault. I am responsible for this event, even though that they're not in our control. Okay. Magnification is another cognitive distortion. Sometimes we make mountains out of molehills, right? We blow things out of proportion. This is, I think, something common that we do, right? Minimization is another cognitive distortion where we downplay the importance of something that's positive, right? And then we focus on something that's more negative, right? So Alyssa might say, oh my gosh, that was absolutely an informative training, right? But because of the way I think about myself, a negative view I have about myself, I might downplay it, right? Or I might minimize the positivity. And I might think that wasn't even that good. Oh my goodness. I don't think she's right. Okay. Arbitrary inference, right, is drawing conclusions when there's little or no evidence. Okay. Sometimes we go to a feeling. I feel a certain way, right? And then I think it's factual. And there's no facts that back up. There's no evidence, okay, of that feeling I have. Overgeneralization is making sweeping conclusions based on a single event, okay? Or sometimes we do that all or nothing, okay? So our cognitions or distortions in our cognitions, again, influence behavior. And then a behavior happens, and then there's consequences. So some of the things that we do as clinicians, right, with our clients is actually take some of those unhelpful thinking habits or cognitive distortions, and we try to identify, right? We try to have an awareness. So if I have a tendency, let's say, mind reading, okay, and I start to notice, wow, I have this habit of mind reading. I start assuming that my partner or my child can read my mind. Okay. If I notice that I do that, I recognize it, I identify that that's what I'm doing. I name that cognitive distortion. And then I want to replace that unhealthy, ineffective way of thinking with alternative ways to think. Okay. And we would do that on the left column of my slide. Those are different cognitive distortions, right? I would think about alternative ways, okay, to replace those distortions. We're going to start restructuring the way we think. Okay. Oops, sorry. Okay. This guy, there's a lot of people joining us tonight on our screens. This guy is Ice Cube. Ice Cube is a rapper, right? But I think he's very important in that if I overlay what he makes a statement in one of his songs, and he says, check yourself before you wreck yourself. Okay. So I think this is sort of like a mantra that I use when I'm feeling a certain way. If I'm starting to get emotional or I feel triggered, right? I have to check myself. And I have to think about, am I having a judgment about something? Am I having an assumption? Is this emotion that I'm having right now, does it fit the circumstance or the situation? I want to take a step back and really check myself because it's going to influence the behavior that I'm going to engage in. Because I want to really prevent as much as I can the consequences of that behavior, which was influenced by that cognition. Okay. That is like the gist of CBT, but we're going to continue. Okay, here's another person who's going to join us. This is Marsha Linehan. Marsha Linehan is out in Washington State, and she has her own research clinic out there. And DBT was developed by Marsha Linehan, okay, out of Washington, D.C. She was working as a cognitive behavioral therapist, and she was providing CBT for suicidal patients, right? And these patients, these clients that she was working with, they were women and they were struggling with substance abuse and they were highly suicidal. And she kept on trying to teach them CBT. And it wasn't working for her clients. They kept on going back and said, you keep saying change, change, change the cognition, change our behavior. You keep saying that and it's not working. It wasn't working because Marsha Linehan figured out that in working with these clients, she kept on reinforcing this concept of change, which is really CBT. And I think it's really treatment, right? When we think about treatment, mental health treatment, we always think about we're changing, right? We want to change the way we think. We want to change our behaviors. they said that they felt invalidated. So Marsha Linehan added this concept of validation. Okay. And what she found was that these treatment impasses became less frequent. And the women ended up feeling validated and motivated. Okay. So DBT evolved, right, from problems that were occurring, treatment failures or treatment issues that were occurring when we were using standard treatments to treat severe and chronically suicidal clients, meeting criteria for borderline personality disorder. Okay. What was going on back then was that they were using CBT, right? Right before CBT, think about it. We were using Freud's psychodynamic model, right? People were in psychoanalysis, I don't know, 3 times a week, right? And they were in therapy for a very long time. Now, when people are in a state of crisis, it's a hard modality to use. Treatment providers were also then using CBT because that became popular in the 70s after Aaron Beck. And then Albert Ellis, right, with REBT, right, which is along the lines of CBT. But for this population, for people who were very depressed and thinking about suicide and actually attempting suicide, CBT just wasn't working. Okay, there's some core differences between CBT and DBT. This is a question I often get. What's the difference between CBT and DBT? And as we continue, you'll see more of the difference. So CBT, the focus is really on change, okay? In comparison to CBT, DBT, we talk about not just change, but we also talk about the concept of acceptance and change. In order for us to change, we need acceptance. If anybody's familiar with the 12 steps, right? AA, NA. In those programs, we accept that we're powerless over alcohol. We're powerless over controlling somebody. We're powerless over chocolate. We accept, and then the 12 steps go, we turn our will, right, over to the universe or a higher power. They use the concept, which is the 3 A's. And I think it's a beautiful concept and it applies here, which is in order for us to change, we need awareness, acceptance, and then action. And you'll see that as we continue tonight. In CBT, we do exposure therapy work, okay? We expose the person to distress. So if a client is struggling with fear of dogs, right? A dog has bitten this client. The client loves dogs, but for some reason, the client gets bitten by a dog. From that point on, any single time the person sees a dog, there's an association, okay, which is based on classical conditioning, okay? So it's paired now. Every single time there's a dog, the person gets activated, they're afraid. So they end up avoiding, going across the street, running the other direction, right? So they end up avoiding the discomfort. See, in CBT, we do exposure work. We might do we might create a hierarchy, okay, of the things that might get us closer to the client becoming less fearful of the dog. Okay. So on that hierarchy, you know, the bottom being the least triggering, right? Or the least distressful that they can tolerate before they go and meet a dog, we're going to take little steps. But it's really exposure, tolerating distress. And we use exposure therapy. In the world of DBT, we also use exposure therapy. Okay. We expose the client to distress, but we also do it again with the acceptance of distress, meaning this feels very distressful. This feels so overwhelming. And at the same time, I'm going to try to do exposure work a little bit at a time. Okay. CBT is problem focused and it's specific. Okay, so somebody might come to me because they're struggling with symptoms of obsessive compulsive disorder, right? So that's what we would be treating, okay, specifically. In DBT is interesting in that it's problem focused, but it's broad, it's inclusive, and we also use a hierarchy. So the client comes for anxiety, right? But the client also reveals when they come for, and did you need something, Alyssa? I don't know if you, okay. Sorry, I thought you were trying to get my attention. So if somebody comes in for the presenting issue, and let's say it's anxiety, right? But while I'm talking to them during the first session, they tell me that they're self-harming, okay, as a way of coping with that anxiety. They also reveal to me that they've had suicidal attempts in the past. Okay. In DBT, I consider all those things, all those elements, and there's a hierarchy. When we say the use of a hierarchy, we think about, we classify it as what's life-threatening, right? Is there something life-threatening going on? Because if there is, that's what we're going to treat first, right? Because treating somebody for OCD or anxiety is useless when the person is feeling suicidal. So we're going to treat that. We're also going to treat the self-harm behaviors because that's also life-threatening. Once we get that under control, then we can treat the anxiety. Okay, so there's a hierarchy. Sometimes what we find with clinicians is that they don't know what to do when somebody talks about suicide. I don't know about you guys here. Sometimes clinicians will end up calling 911 or end up telling the person that they need a hospitalization. Okay, because this is the way we're trained as clinicians. In the world of DBT, of course, we would use 911 if we need to. Okay, but it's different. It's different when we're DBT therapists. Okay, we talk about suicide. We put it on the table. We talk about self-harm. We put it on the table. We talk about it. We don't go, oh my God, suicide? What are we going to do here? No, you'll see the difference between somebody who's trained in DBT versus somebody who's not trained in DBT because it's part of the treatment. Okay, so those are the core differences. Now, in the world of DBT, okay, DBT was really developed for and targeted for individuals meeting criteria for BPD, borderline personality disorder. Okay, and we will talk more about that. Okay, So we use, when we talk about development of disorders, we tend to use the interactional model. Okay. And this, it goes like this. So the interactional model is if two, if a couple, right, has two children, let's say, right, one of the partners has a diagnosis of schizophrenia, let's say, right? There's a high chance that one of the children or both of the children, they're at risk of developing schizophrenia, right? So when we use the interactional model, if a stressful event happens to one of the children, that stressful event pushes that person's threshold, right, for that stress, and it could activate that propensity for developing schizophrenia. Okay. The other child, maybe that child didn't experience anything stressful. He might not develop schizophrenia. Okay. We use a transactional model when we talk about personality disorders. Okay. And I think this is an important slide. Okay. Because often clients will come to me or family members will say, how did this happen? Why does my family member struggle with their emotions? Why is my child, why is my loved one diagnosed with BPD? How did this happen? So this is how Marshall Linehan has developed it. Okay. And I wanted to say, we're not using this model to blame anybody. Okay. I have to say that because sometimes family members end up feeling horrible. Okay. And that's not the intention. Okay. So transactional models are common ways of understanding the development of all kinds of behavioral repertoires, okay, in social interactional settings. We use Linehan's biosocial theory. So the person comes into this world, okay, and they are innately emotionally vulnerable. They're just highly sensitive. They're just highly sensitive. Sometimes people are not sensitive, right? They go with the punches. Is that a term? Is that a term? They roll with it, okay? They're just not highly sensitive. But that person who's emotionally sensitive and vulnerable grows up in an environment where it's invalidating. It could be a family, it could be a culture, it could be institutions like the community, right? Communities. It could be schools, right? But that person grows up in an invalidating environment that doesn't know how to validate or how to get along, or that environment just it's not a good fit, right? Sometimes it's just not a good fit. Some of us have children or partners, we're just the opposite. We're just different. One person is highly sensitive and the other one isn't. We get into a lot of conflict, right? This is sort of what it looks like. I'm just going to use a child and parent dyad here. Okay, so A is the environment. B is, can you see when I do this? Okay, so B is the child. Okay, the child is highly sensitive, but the environment is not. Okay, they go, stop crying. What's wrong with you? Oh my God, get over it. Okay, the child starts to cry more, right? And then the A goes, oh my God, this is so frustrating. Go to your room, time out. Okay. That kid ends up feeling invalidated, feeling like, oh my gosh, my environment doesn't care about me. Right. The kid comes home and says, I'm going to kind of use my culture. Right. I'm Korean, Korean American. So I come home with my report, a report, okay, and it gets graded. I get a B plus. I work really hard, and my mother says, "Huh, B plus? What's a B plus? You mean an A? What happened? I worked very hard," and she says, "You got to try harder." Wah wah. Right? I end up going, "Oh my God, I work so hard, and it's not acceptable. I've just been invalidated." Okay. Something happens, I get bullied, I go back to A, and A says, "What did you do wrong that your friends bullied you?" Okay. Over time, to get the attention, I might cut. I might take a razor and cut. In that moment, my mother might say, "Oh my God, my darling, you're bleeding. We got to get you help." In that moment, that individual has just learned that if they cut, they might get attention. They got validation. Okay. So for the next couple of months, couple of weeks, they're getting a lot of validation, but then it returns. It doesn't stick, right? It goes back to this back and forth. I don't get the attention. Now I've grown accustomed to cutting. Okay. I've adjusted. I've built a tolerance. Okay. I end up swallowing pills. Okay. I didn't intend to hurt myself. But again, my mother says, "Oh my God, we got to get you to the hospital." We end up going to the hospital. I get admitted. Everybody's giving me attention, the validation that I needed. Okay. So sometimes this transaction, right, occurs and the person ends up feeling invalidated, right? Over time, they can't identify what the feelings are because any single time I have feelings, it gets shunned or people avoid it. I'm overreacting. I'm too sensitive. Okay. So I question my ability to label my emotions. Maybe I shouldn't get mad. Maybe I don't express myself, right? Um, I also can't develop coping skills. We're not born with coping skills. It is learned from our environments, whether it's school, our communities, our parents, our siblings. We're not born with coping skills. So that person who's highly sensitive, if they're crying or they're having a hard time problem solving, and nobody is helping them problem solve, where is that person going to get and learn their coping skills? Okay. So coping skills are essential. And I think in invalidating environments, that's one of the things that's lacking. Okay. This slide, I sort of frame people. You're going to all be like, is she talking about botany now? Okay. So I sort of frame people. So I went to a training, some of my colleagues, right? We talk about, are you an orchid? Are you a dandelion? And in the beginning, I was like, what are we talking about here? Okay. So I sort of classify how we are as flowers. This is how I sort of categorize it. I think flowers are lovely. So, okay. Um, Orchids are highly sensitive, right? They're beautiful. They're expensive. When they're blooming, they're majestic. They're beautiful flowers, right? they're highly sensitive to their environments. We're plucking them out of, I think, a tropical-ish climate, right? And we're putting them in our on our windowsills and going, please don't will, please don't will. There's orchicides every single day because there's no formula. I've I've heard people go, you just put an ice cube in the soil, you melt it, too much water, too little water, too much sunlight, too little sunlight. They're just highly vulnerable to their environment. Okay. Dandelions, right? We consider them weeds, but they're still flowers. Dandelions are hardy. They go with the flow, right? Too much water, too little water. I mean, too much sun, too little sun, drought, rainfall, you name it, right? If the sun is like really hot, they survive. They go with the flow. So the orchid goes, the orchid goes, ouch, they gave me too much water, right? The dandelion partner goes, yeah, and what's the big deal? We see this sometimes in couples therapy, right? I see this in couples therapy. One partner goes, I don't like it when you say that. That really hurts my feelings. I don't know why I'm talking like this, but right. Oh my gosh, that really offended me. The person who's more like an dandelion goes, yeah, what's the big whoop? And the orchid goes, I don't like it. It's offensive. It's invalidating for both flowers. Okay. So think of the person that's in front of you, the person that you love, right? Is this a person an orchid or a dandelion? What am I? Am I an orchid or a dandelion? Okay. In my relationship with my daughter, I always thought she was a dandelion. It turns out she's an orchid. Okay. In her adolescence, she says, I'm highly sensitive. She goes out and buys a book for highly sensitive people. And I go, wait, who's reading this? And she goes, me. Okay. So it really made me think about how I'm going to relate and communicate with my kid. Okay. I think it's just a helpful way of framing the people that I love. You're all going to be like, and what am I? Am I a rose? Okay. This concept of validation, invalidation is so important. I often ask clients, who validated you growing up? And they go, what? What does that mean? And I go, validated your feelings when you were feeling sad. They were able to say, oh my gosh, I see that you're sad. What does that feel like? Right? They often say, no. People say, get over it. Stop it. Okay. Invalidation, the definition is denying or ignoring a person's emotional experience and communicating that their thoughts or feelings are not valid or wrong. We do it unknowingly. When our feelings and needs are not validated, we learn to internalize invalidation. We start to question ourselves. We start to doubt ourselves. We end up minimizing, dismissing our feelings because of that invalidation. Okay. When we talk about validation, a lot of family members have a hard time saying, I'm not validating that person because it means then they're right. Validation is not about agreeing or condoning a behavior. Validation means I'm curious about how you're feeling. I want to understand because I don't understand. Okay. There are, in the world of DBT, what I learned is that there's 6 levels of validation. Okay. I'm just going to do one. The first level is just being present, listening. I don't have to do anything. I can just listen. You guys are all very validating because you're sitting there listening. Okay. V2 is the second level of validation. It's accurately reflecting what you're hearing. So what I'm hearing from from you, Alyssa, is that you didn't need me. Okay, I thought you did. Thanks for that validation. In the presence of validation, in the presence of validating environments, we learn to validate ourselves. When there's no validation in invalidating environments, we don't self-validate. When there's nobody to validate us, we know how to validate. Good job. This is really hard to do. And you took steps to do it and you threw yourself in there. Okay. How many of us invalidate ourselves? We do it all the time. We say negative things, those negative distortions, right? Those cognitive distortions in the world of CBT, we end up doing it. Okay. Dialectical what? So people come to me and they go, my therapist, my psychiatrist says that I need dialectical behavioral therapy. And I go, okay, what is it? And they go, I don't know, something about language. I go, close, but not really close. People don't even know what dialectical means. Okay. Take a second, right? What do you see? Okay. You see something. Okay. Some of you are going to say, I see a young lady with her head turned. She's wearing some sort of head thing, right? Some of you will say, what is Jackie talking about? What young lady? I see an older lady with a hat, with black hair, and a fur-like jacket, stole. Okay. And some of you are like, what is she talking about for real? I can't wait till we get unmuted so I can tell her. Okay. This concept of dialectics means at any given moment, we can have two opposing views and they can coexist at the same time. We can have two opposing ideas and they can both be true. In the world of DBT, we think that there is always more than one way to think about a situation, and all people have something unique and different to offer. Okay. So my partner can come in and say, it's freezing in here. And I go, freezing? Oh my God, I'm sweating. Those two truths are both true. Okay. Dialectics in DBT, we think about the thesis and the antithesis, and we think about the synthesis. We think about what's the middle path. We honor both truths. Okay. We emphasize both. We don't use the word but. We replace it with the word and. Okay. I love you, Alyssa, my child, and your room needs some sprucing. Okay. They're both true. Okay. Okay. So this is the big difference between CBT and DBT. DBT is a synthesis. CBT is the cake. It's the cake that we need. It's the foundation. Without CBT, there wouldn't be DBT. Okay. It's a synthesis of DBT, dialectical theory, those two opposing views, and Zen philosophy. Okay. Marshall Linehan introduced Zen philosophy. It is not a religion, it's a practice. Okay. And it's very similar to other contemplative and meditation practices. It's not religious. Okay. Okay. So common elements in contemplative practice is about compassion, love, radical acceptance, and wisdom. Okay. We approach our work that we do with our client with those elements. We borrow from Zen, Buddhism. Okay. And we think about this idea about the noble truths. This is an important slide in that the first truth is that life has suffering. Life is suffering. The avoidance of suffering is going to lead to worse suffering. Some people hate that slide. So I'm going to replace it. That life has anxiety. The avoidance of anxiety leads to more anxiety. The more I keep avoiding that dog that bit me, the more anxiety I'm going to have. Radical acceptance is a Marsha Linehan concept in DBT. Okay. There are 3 parts to radical acceptance. The first part is accepting that reality is what it is. It is what it is. The second part is accepting that the event or situation causing you pain has a cause. And that the third part is accepting that life can be worth living even with painful events. April 15 is tax day. I need to accept the reality of it. I can't change it, right? It's causing me pain, okay? There's a cause for it, right? But life can still be worth living after I file and pay my taxes, okay? We can't change things. So this concept of acceptance, okay? Pain plus non-acceptance, guys, equals suffering. Acceptance is the entrance to change. That's really our ticket to change. You need acceptance before you can enter. Okay. And this is a very challenging thing for us to do. Okay. Now, this slide are the 4 core modules in the world of DBT. Okay. You come in for therapy, right? DBT, to its fidelity, we require that the person is in individual therapy and also skills therapy, skills training in like a group setting to learn skills. It's like a classroom setting. Sometimes folks can't afford that, okay? Or we don't have resources. So I end up teaching those skills individually, one-on-one. Okay. The first skill, and we'll talk more about this, but this slide is important in that even the skills are categorized as acceptance skills and then change skills. So really the first 2 modules that we go over in DBT are mindfulness skills, the stress tolerance skills, which is the acceptance skills, and then we learn the change skills. And those are the emotional regulation and interpersonal effectiveness. And you'll see the skills as we continue how it works. Okay. So is it mindful or mindful? Okay. Mindfulness, borrowing from John Kabat-Zinn, who's the daddy of mindfulness practice, right? He says mindfulness is about paying attention in a particular way on purpose in the present moment and non-judgmentally. You guys right now are all practicing mindfulness because you're sitting in this moment. So the thought is the only moment that we have is right now. For me to start thinking about what to eat later, I can't be present in this moment, right? On purpose. So I bring my attention here. Okay. This slide is very important in DBT, and some of you might have seen this Venn diagram. We all experience the world either using rational mind or emotional mind. We orient to the world. We make decisions based on rational mind or reason mind, and then emotion mind. Some of us, right, think about, we approach life situations using facts, logic. I want the policies and procedures. What does the law say, right? Those of us who operate from emotion mind, oh my God, that's so cute. I love it. I'm 5 minutes late. Okay, no biggie, right? I was caught up in traffic. Okay. We tap into the emotion part, okay? Where we want to operate as much as we can is an overlap of rational mind and emotion mind, and that is wise mind. Wise mind is the place where we intuitively know how to make a decision. It's a balance between the two, and it's living mindfully. Okay. Wise mind is mindfulness. It's another word, phrase for practicing mindfulness. So, how do we practice mindfulness? Okay. There are two distinct skills in mindfulness in that module. Because people say, how do I practice mindfulness? I can't meditate all day. And I go, it's part of it, but it's more. Okay. So there are the what skills, and the what skills would be the observe skill. I just want to notice. I notice my environment. I notice what I'm feeling, a sensation, without reacting to it. Okay. I allow my thoughts and sensations to come in and out, right? Describe is noticing and then describing, using words to describe what I see. It stays factual, and it stays factual. It's not about feelings. It's not going to be, my God, I notice my room, my office is really messy. That's a judgment. Okay. We're just noticing, observing, and describing what we factually see. Participate is the third skill of the what skills. And that is to throw ourselves in the moment. I'm fully participating in this moment. I'm not frying an egg. Why am I frying an egg? I'm not frying an egg and trying to do this training, right? It's incompatible. I want to participate in this moment. Okay. If I'm going to have anxiety about something, I want to sit in the corner and I want to throw myself and do that well. Okay. But right now, I'm going to participate. The how skills are broken down into non-judgmentally, which is letting go of judgments. Check yourself before you wreck yourself, right? If I have a judgment, right, that's going to influence behavior. I neutralize the judgment that I notice. Okay. One mindfully is the next step. Again, that's doing one thing at a time. We don't think about the past and we don't think about the future, because we know when we focus on the past, that's depression. When we focus too much about the future, that's anxiety. We want to be here in this moment. Okay. We will also want to be effective. We want to act effectively. If I'm not being effective, I need to stop and pick a different route. Okay. Okay. Oof. Feelings. When you look at this slide, some of us might have feelings. Okay. So just take a second, right? In your head with this exercise, you want to just think about, am I having judgments? If you were to notice, and maybe think about 3 things that you see factually, that's what you want to do in practicing the observe skill. Okay. We're not going to go, oh my God, what's this? It looks like my office. Oh, I'm such a slob. It goes back to judgments again. So we're teaching ourselves to neutralize judgments and assumptions. Good job. You just finished quickly the mindfulness module in 5 minutes. It takes much longer, I have to tell you, when we're doing therapy, because mindfulness is one of the most difficult skills to work on. Okay. The next acceptance skill, the next module would be the distress tolerance skills. And these skills help us how to tolerate high distress without making things worse. Okay. These are skills to get us out of short-term challenges. These are not for long-term. Okay. It helps us tolerate an uncomfortable situation. Okay. DBT, according to Marsha Linehan, I think she's just full of wisdom, Marsha Linehan. She emphasizes learning to bear pain skillfully is it's essential, okay, to living. The ability to tolerate and accept distress is an essential mental health goal for at least two reasons. First, again, going back to one of the noble truths, right? Pain and distress are a part of life. They cannot be entirely avoided or removed. Even though I might not have caused it, pain and distress are part of life. The inability to accept this immutable fact itself leads to increased pain and suffering. Second is that distress tolerance, at least over the short run, is part and parcel of any attempt to change oneself. Otherwise, right, impulsive actions will interfere with efforts to establish desired changes. We have to be able to tolerate discomfort. Okay. Okay. Marshall Linehan loves acronyms. Okay. One of the skills in distress tolerance is what we call wise mind accepts. Okay. So the A stands for if I'm feeling really stressed out, if I have an urge to do something, let's say I have an urge to yell at my partner, right? I can engage in an activity. I can contribute, right? Volunteering to do something helpful. I could wash the dishes for the family. Comparisons, I can compare my situation, right? I'm not going to compare myself to somebody who's in a better position than I am, because then I'm going to feel miserable. I'm going to compare my current situation maybe to a past challenge that I've overcome, right? Emotions is I'm going to stimulate emotions that are incongruent to the current emotional state. So if I've identified that I'm angry and I want to start screaming, I might want to listen to the Beatles. I don't know. Here Comes the Sun. I might watch something that's funny, a comedy. Okay. We want to change that emotion to the opposite. Pushing away is temporarily leaving a situation, mentally or physically. I notice I want to yell, I put it up on the shelf, right? Mentally, and then I walk away. Thoughts are just concrete things I can do. Counting all the colors in a room, saying the alphabet backwards. I wear a bracelet with seed bead, little baby micro beads. And so I might sit and count the beads. Okay. I might count the slats on my shade, the books in my book on my bookshelf. Anything that's concrete to distract me. Sensations is using five senses. Sometimes I have to light a candle if I'm doing Zoom, if I'm stressed out, right? Just to change, just to get me down, right? If I'm stressed out. Another skill is self-soothing, which is using our five senses, right? Sight, low lighting, right? Coloring books. Sometimes my clients love the coloring books. Sound, right? Listening to rain, YouTube rain, some classical music. Sometimes some people don't want to hear anything, right? Touch, weighted blanket, sometimes a cold or a hot shower. Children love stuffed animals, right? It soothes them. It's self-soothing. Smell, aromatherapy, going out for a walk, candles, taste. I discovered chocolate during COVID. I don't really eat chocolate, but I rediscovered it, right? That helps me self-soothe. Improve the moment is another skill. We use imagery, right? Think of an image that's meaningful and soothing. Visualize that, right? Meaning, tap into what's most important. What is the meaning of the thing that I'm going through? Okay. Prayer. Sometimes we can use prayer. Some of us don't like to pray. We can use a mantra, right? Lyrics to a song, anything to ground us. Relaxation, right? progressive muscle relaxation. I put on John Cabot's body scan and YouTube. It doesn't matter if I'm at the pool or if I'm, laying on my bed, knocks me out. He's got the soothing voice that relaxes me. One thing in the moment, doing one thing at a time. Vacation, right? It could be imagining, or I can go on vacation, right? Encouragement, being our best cheerleader. We want to improve the moment. We don't want to make things worse. We can do pros and cons, right? Acting on an impulse versus not acting on an impulse. When we have decisions that we have to make, we use the pros and cons to help us figure out what to do. The tip skill, I think is such a great skill. It's easy to remember. Okay. So sometimes when my clients are really having a hard time, we get activated and we get hot. Okay. The sympathetic nervous system gets activated. Some of us start sweating. Some of my clients grab ice, right? And just watch the ice melt. It changes the temperature, running cold water, right? On our pulse points, intense exercise. The reason why we do intense exercise is that it activates the parasympathetic nervous system. And that brings us back down. Paced breathing, just breathing, paired muscle relaxation, right? So tip is like, it's just a portable distress tolerance skill. Emotion regulation, I love this skill, this module. Emotion regulation helps us regulate ourselves. I don't know about you guys. I've dysregulated on many occasions, right? So this module really helps for us to understand emotions, right? So how can understanding and regulating emotions help clinicians or individuals be more effective? Okay. The goal of emotional regulation skills is to help us understand what the emotion that I'm feeling, reduce emotional vulnerability. Some of us are highly sensitive and highly emotional. It also helps us decrease emotional suffering. Okay. This is all of our brains, I think, right now. Okay. We're at baseline. Right now, our prefrontal cortex, right, is active. That is the seat of logic, reason, executive functioning. You guys can remember what you had for breakfast this morning or lunch, right? The amygdala is the seat of the alarm, right? The emotional seat, which is part of the limbic system. And this is where the fight or flight area is. The hippocampus is responsible for memory. Right now, you can think about, again, what you had for breakfast this morning, what the temperature was like today. But if I said, okay, right now I'm going to administer tests to all of you, and we're going to score it. And for every wrong answer, you're going to owe me $5. Okay. At that point, oops, your amygdala gets activated. When that amygdala, the smoke alarm goes off, an interesting thing happens. Your prefrontal cortex gets deactivated. They do not work in tandem. Your hippocampus also gets deactivated, right? So if the smoke alarm is going off in Alyssa's house, right, and I go, hey, Alyssa, can you help me with this math problem? There's a high likelihood she's going to say, not now. And I go, Alyssa, can you help me? She's going to go, not now. She might yell at me, actually. Okay. They don't work in tandem. So the amygdala activates the sympathetic nervous system. The cortisol levels are through the roof. I'm sweating. All that stuff happens. We want to activate the parasympathetic nervous system. Okay. This is what happens. Just like the CBT, the ABC. Something activating happens. Something happens. Let's just say a stimulus. Something happens. We interpret that stimulus. Okay. We go, oh, Alyssa doesn't like me. Oh my God, she's not even smiling at me. Okay. I get triggered. I'm concerned that she doesn't like this training and she's wasted all of her efforts. In that moment, I make a judgment. Okay. I look at Alyssa, my amygdala gets activated, the muscles on my body and my face get tightened, right? There's a sensation to start crying or to put myself under my desk. Okay. The interpretation of a stimulus, we need to think about that because that's the thing that activates physiological changes. Okay. And that is how emotions get activated. Some of the skills that we use. Number one, I'm just going to go back to this slide. We always have to check vulnerability. Did I eat? Am I tired? Am I sick? Because normally I wouldn't be this activated. So we check for vulnerability factors. And one of the first things that we always think about is we need to reduce vulnerability. Okay. Because if we're sick, right? If I haven't eaten, if I'm taking mood altering drugs, right? If I didn't get sleep or exercise, that increases our vulnerability. And that might not be the best time to have a conversation. Okay. We use ABC please, which is A is accumulating the positives, building positive experiences, being mindful about the positives, because sometimes we go to the negative always, right? So we want to start accumulating positivity in our lives. We also want to start B, building mastery. Every day, trying to do one thing, an activity, so that we get a sense of accomplishment. Okay. Do something difficult, but something that's possible for success. Okay. We also do C, which is cope ahead for emotional situations. So if I know I'm going to be with my family and my family triggers me there's a bunch of holidays coming up, right? There's Passover, there's Easter, tax day, if that's a holiday, right? I want to cope ahead. I want to go, okay, with my therapist, with my friend, I'm going to think about in the event this happens, how can I problem solve? So I'm not walking in without like a toolkit. Okay. Another skill, and I think this is another beautiful skill, which is opposite action to emotion. So that A, B, C, we can actually change cognition if we change the behavior. Okay. We can change an emotion if we change the behavior, right? There's that tattoo again. So, or we can change the emotion, right? By changing the action, like I said. If I do something opposite, right, I'm going to change that emotion. So for every emotion that has an action, it has a different emotion. So if the emotion is I'm fearful, the action urge is for me to run. I'm going to do the opposite. I'm going to stay and try to face my fear. If the emotion is anger and I want to attack, I'm going to do the opposite. Maybe I can't do a full smile, right? But I might do a half smile. I might not be angry I might not attack, but I might try to listen to that person to the best of my ability. If I'm sad, the action urge is to withdraw. If I'm sad, I might try to tolerate that discomfort using those skills from the distress tolerance module and talk about my sadness. Shame, okay. I might want to hide, but I'm going to face my shame using opposite action. Okay. A big skill, and this is again a very difficult skill, is to ride the wave. I have an urge to yell. I'm going to ride the wave. I'm going to urge surf. I might have the urge to eat that piece of chocolate after I've had two, and I'm going to ride the wave and not not eat it. Okay. The last module, and this is again a difficult module in practice, right? Is the interpersonal effectiveness module. Some of us have a really difficult time asking for the things that we want and what we need, and we end up internalizing it. So the interpersonal effectiveness module helps us attend to relationships. It helps us balance priorities versus demands, and it balances the wants versus the shoulds. Okay. Wants and shoulds is a judgment. Okay. If I should be doing this is a judgment. Okay. Dear man, we use when we want to get something. If I want to ask my spouse to take out the garbage, right? Because I always take out the garbage, but maybe I'm afraid to ask. I would use dear man, which would be describe the situation, express how you feel, ask for what you want, and reinforce the other person by being mindful, appearing confident, and be willing to negotiate. So it might look like, honey, I noticed that I've been taking out the garbage for the past 2 months. It would be very helpful if you can take out the garbage. Would you be able to take out the garbage this month? Okay. We want to reinforce that person. Honey, does that work for you? Right? I want to be in the moment. I want to appear confident. I'm not going to say, oh my God, I'm so sorry. Sorry. Can you take out the garbage? Oh my God, I'm so sorry. Right? Some of us do that. Okay. After we ask for the thing, listening to somebody, we use the give skill, like this doggy, right? Hello. The G is be gentle. When he's going to answer me about the garbage, treat that person with respect. I is be interested in what that person is going to say, even though I'm sitting here going, I don't know what he's going to say. I'm interested in how he's going to say it, right? Validate what the other person is saying. Oh, so you're saying that you've been busy the past 2 months. I understand that, right? And thank you. Thank you for saying that you're going to take out the garbage. Do you mind if I remind you the night before, right? We want to always be easy mannered. When we notice that we're not being easy mannered, there's something going on, right? We're getting activated. We want to pay attention to posture, tone, right? And the volume. We also want to check intensity, right? Okay. Fast is the skill for building respect for myself, right? Being fair to yourself and to others. We don't apologize for making a request. Some of us, oh my God, I'm so sorry. Sorry. Is that okay? Sorry to bother you. Sorry. Okay. Stick to values and be truthful. This beautiful card, this is what's called a diary card. And in DBT, our clients, when they learn each skill and move through the skill, they actually on a daily basis will circle the skill that they've practiced. This diary card is very helpful in organizing the skills and helping us, including myself, practice and generalize these skills. Okay. So the question comes up, is DBT treatment helpful for other disorders or other issues? And I go, oh my God, yeah, yes. It's been highly effective and it's research-based. And I can give you the research, okay? It's been researched for substance abuse, eating disorders, personality disorders, affective disorders, self-injury. My colleagues are teaching DBT skills. It's infused in the West Coast in their health curriculum, okay? We teach DBT. We adapted for middle school children, right? Adolescents. We adapted for substance abuse, it's DBTS. We adapted for people with, learning challenges, right? Okay. Oh, here they go. Okay. So when I first started DBT training, there weren't too many of us. Okay. People weren't getting diagnosed with BPD when I first started out. Okay. We see that it's less stigmatized now. We see TikTok. Okay. Selena Gomez on my left talks about how it was effective. The DBT therapy that she was in was very effective. Lady Gaga, right? She also raves about the efficacy of DBT. Okay. So, when faced with a difficult situation, there are 4 choices in DBT. Choice 1, solve the problem. Choice 2, change the way I think about the problem. Choice 3 is radically accept the situation, radical acceptance. 4, if you'd like, you can stay miserable. Just keep complaining, right? And then there's always choice 5, guys. No matter how bad things are, you can always make things worse. Okay? We tend to think about choice 4 and 5, but there's alternatives for problem solving. Okay. So there's my crew. CBT, DBT, theorists, rapper, and then the 2 celebrities. Okay. That's it. I'm going to stop sharing. There we go. Oh, that was a mouthful. I just